Welcome to Psychological Explorations with Dr. Michael Axelman and Daniela. Today we're going to be exploring the frame in psychotherapy and exploring also some typical responses that therapists have when engaging in the frame and topics around the frame, and how their own personality dynamics kind of influence. Our general goal here is to raise awareness for therapists and other people who are interested in understanding the importance of the frequency and the place for the success in psychotherapy. So we have these two key features: the therapist and the frame. This is what we have to work with. Therapists need to think of the frame as their friend, their collaborator, this opportunity to create this environment at particular time, which provides containment, care, reliability. So as such, the therapist is thinking about the frame, and they're thinking about the modalities and the approaches that they're using in the particular setting. In our discussion today, we're going to contrast some different settings: the model of independent therapy and counseling, one-to-one, and the model of the community setting, which is much more fluid and dynamic and has a real local flavor to it that needs to be incorporated into the work. If the therapist isn't thinking about the frame, they're not fully thinking about the psychotherapy process. If you can think about the image of a person standing in a room and trying to find the wall on the right side, and the hand goes searching and searching and searching, and then reaches the wall and puts pressure on that wall, and the information this provides for the body and the mind, that there is a firm limit that has to be experienced and encountered and reckoned with. And the wall can be a prison, it can be a point of safety. It all has to be explored in the transference. So the frame includes a setting, a place, an office, whatever that place of regularity might be. Sometimes it's taking the same walk on the same trails for children who need more movement. And then there's this agreed upon time each week at this time. This is your time. Now, the frequency may be increased. There may be reasons to decrease it. But typically today we'll be talking about kind of once a week, 45-minute to 55-minute one-on-one therapy as the model. Daniela, maybe you could at this time share some thoughts about independent practice versus community setting.
Absolutely. I can certainly talk to the community setting since that's what I've been doing for the last 6 years. Um, I think one of the things when it comes to the community setting that's different from independent practice or private practice is that we become extremely accessible, not to just our clients, but to a whole clubhouse. So not just a caseload of 20, but a group of 100, 120. And one of the things that happens a lot in the community setting is that we have our caseload, but we also have a lot of students who are interested, connected, want to be around the therapist or the therapy setting. And I think that's for a few reasons. One is that we're really tolerant, we're patient, we're curious about them. We don't engage in discipline or any sort of reprimands like that. How we usually respond to sort of those kinds of issues is by wondering what was going on for the student or the client at that time. And so the kids really like being around us or in our space, but that creates a different set of issues and problems, and one in which we have to maintain a frame with our clients. We also have to have a framed approach to all of the youth. And so one of the things that we get really good at is being fluid but firm. I have one student, here's a good example of what I mean by this is there's a young man who I've known since he was in 8th grade. He's a rising junior now, so he's finishing up his sophomore year. And we often joke at the clubhouse that he's my shadow. So if I'm not in session or I'm not in the middle of a meeting and I'm available, he's with me. And because of this, when I have another session, let's say at 5 o'clock and he's with me, I have to give him the 10-minute warning, right? At 4:50, you need to go your own separate way. I have these other things that I need to get done. And at first, it's been very challenging to get him to go off and do his own thing. And so I've had to front end some of these conversations. I've done it is disappointing when you and I have to separate that thing. But what's really worked, and this is really interesting, and I think a reflection of his development, is the countdown like you do with young kids, right? Okay, I need you out of my therapy space at the
Mm-hmm.
count of 10. So then I count backwards. And he does the whole thing where he moves really slow. And then when I get to about 2, he starts packing up quickly. And when I hit 1, he's running out of the office. Um, and he's a 15-year-old boy.
Yes.
But he's had
Oh,
disruptions in his attachment.
oh,
So
it's wonderful how he brings you into that kind of regressive enactment.
absolutely all the time. And so he's not a client. He refuses to be in therapy, but he loves being around the therapists.
Mm.
So these are some of the challenges that we have. And I'll say when we do structured therapy,
Mm-hmm.
our informed consent looks a lot different. It looks like that, like of a small town, right? You might see me out and about. You might see me with your friends. You might even see me with people you don't like. You might see me with the director in a disciplinary meeting or something like that. Um, so you're going to see me in these other aspects of the environment. And those are things that we need to talk about if they become issues for you. So we do the informed consent a little bit differently like that.
Mm-hmm.
And I think in the community setting, the frame becomes one of the most important aspects of our work because it informs not just
Mm.
um, how we do things, but it also allows us to engage in process that we wouldn't normally be able to engage with. Things are happening more in real time. Enactments are everywhere because the benefit is we're more accessible and we get to see them and be around them.
Mm-hmm.
But that creates some challenges on our end. But I don't have any experience in independent practice.
Mm-hmm.
Maybe you can speak to that a little bit, Michael, and then we can see how it's different.
Yes, I mean, you give this wonderful example of a child who hasn't started formal therapy, but has been engaging in long-term informal therapy with you,
Yes. Yes.
right? Um, and I think that in some ways is the hallmark, right, of the success in the community setting
Right.
is working with somebody, right, with yourself and with the frame, right?
Yeah.
And you establish the frame in such a wonderful way, right? You need to go, right, and do your independent things at this time.
Yes.
Right. The communication to the child is not that I need to go attend to other children at the center, even though that is a truth, right? That's not
Right.
what needs to be communicated in that moment. You're so aware of that,
Yes.
right? It's that we're going to set a limit here, right? Right. For the toddler, it's that mom's going to go attend to another sibling, or mom's going to go and shopping, or mom's going to go to work, whatever that is, right? The child needs to integrate that disappointment, and
Yes.
the relationship deepens right at that moment. So the
Yes.
deepening happens at the limit, and the frame is that holding environment.
Absolutely. And that is something that I share with my supervisees all the time, is that the relationship becomes real when we set the limit. And that is true of this student. That's true of all the students that I work with. One of the things that helps me and some of the things that I coach other staff on is you have to have limits with the kids so that they know that you're real, that the relationship is real. Otherwise, it just stays in this fantasy, and then it comes crumbling down if not, you know?
Absolutely. Right. The disappointment must be faced,
Yes.
right? That we have to work within the confines of this frame,
Yes.
right? And you provided the frame that there's this time for you after school, and before I start my next activity, that we can have this informal time together. And then you have to accept the ending of that
Yeah.
time.
Yes. And what's really wonderful about this too, Michael, is that like this young man now, he's more open to other things. Like he's helping out the volleyball team at school, kind of like the ball boy, like the coach's assistant.
Mm-hmm.
Those are things he wouldn't normally have done. He was the kind of kid who likes
Yes.
to sit on his phone and put his headphones on and not talk or be with anybody. But now he's putting himself out there a little bit more, which is really,
Mm-hmm.
wonderful to see.
Yes.
Yes,
Oh,
there's a
you
lot.
can really
Of,
see it.
oh yeah, there's a lot of improv in the community setting, and you have to have a certain type of attitude, and outlook towards the community to succeed in it. It's not. It's really not for everybody.
Yes. Right. Well, you have to tolerate a tremendous amount of uncertainty,
Yes.
right?
Yes.
Because the frame is less clarified, where in independent practice, there will be somebody or a family in your waiting room, and they'll come into your space that's very well defined and it's been clarified. And there's this joining that happens prior, right? Where you're kind of in some ways promoting the value of relationship and the possibility of relationship.
Exactly. That's exactly right. That's how we think about things. That's really what our program is rooted in.
Let's move forward and learn a little bit more about changes to the frame. So, a child, an adult, comes to a session with a request to change the frame. And there's a part of this that really wants to accommodate the client, the child, and be responsive to what they want in the moment. And then there's another part of this, right, that's rooted in our professional sensibility that knows that, the frame is our friend and it only works if it's not modified all the time, right? The frame works because it's immovable. That's how it has most value for us. So, how to take in that request from a client and move it into awareness, curiosity, wondering about why now you might be feeling that way, that it's time to end, or it's time to move to every other week, or whatever that request might be. You're bringing up a lot of great points. Wow, you've thought about this a lot. I feel like we need to meet next week and really discuss this more fully. So you use the frame in the moment to bring the client back into that conversation. So we use the frame to explore what might be behind the feeling of wanting to change the frame. It's often a reenactment of an earlier event relationally. And there's tension that can't be tolerated and can't be worked through. And the tendency towards emotional cutoff is very high. Daniela, perhaps you could speak
Yes,
to your experience of kind of the countertransference and how it informs, tendencies to react.
absolutely. Yes, I have two great examples. One of a clinician that I supervised, a brilliant clinician that I supervised, and a client that she inherited. And then I have my own example. So I'll move us into the next slide, which is the countertransference, right? It's that anxiety that we have in that interpersonal encounter. I consulted with you quite a bit on this case, and we actually talked about it a few discussions ago about the fear of the breakdown. This was this client. And when I was working with them, we were meeting at the twice a week frequency. And when things started to get really, I think, real between the two of us, the client asked to go back down to once a week. And in my anxiety, in my countertransference, in my probably the feeling of like, shit, things are getting real, I said, okay. And that's not something that I typically do because I've been working with you for a very long time and I know not to do that. And yet I did do that. And so for me, that felt very significant. This was also a student or a client who I remember after a session hearing the phone ring and just instinctually running to the phone, which I typically don't do either, and answering it when I saw it was them. And then at this point, I started to understand something's happening here because I'm adjusting and breaking and acting out in the frame myself. And this was a case that was really, there was a lot of countertransference that I didn't understand, that you helped me understand. But it was this moving the frame on the spot, answering phones outside of our session time. This was my own sort of anxiety. And I think the projective sort of, I was identifying with some of her projections as well. And I felt just unsettled sometimes.
Yes. Oh, it's remarkable how these projections can come into us and modify us, right? And compel us to do things that we know are wrong. We know that
Yes.
we should not be doing, right? It's just remarkable
Mm-hmm.
the way that enactment will happen out of awareness or with, a little bit of awareness, not full,
Right.
right?
Mm-hmm.
Um,
And then, I do have another example that I think is really interesting of a clinician that I supervised. She's really brilliant, just naturally brilliant, framed, all these things. And she inherited a client um, who the agreement with her therapist was they would have the sessions as long as the client wanted them. So it could be 5 minutes, it could be 2 hours, um, and when the client wanted them, because the client's presenting issue was difficulty in relationships. And so I think that the
Hmm.
therapist before was maybe working under the idea of wanting to create safety, wanting to give the client sort of control and autonomy over the relationship. So I could kind of see where they maybe might have been going. And it was a newer clinician as well. But then when my clinician that I was supervising took the client on, she basically said to the client, well, you know, if this is an issue around relationships and we have to make sure that we're meeting for a certain amount of time at the same time every week so that we can work through this anxiety that's coming up for you. And so they agreed upon 30 minutes and they did that for a few weeks. And then the client could do 35 minutes and then 40, and then they worked up to the 50-minute mark. And then over the span of about a year, the client was able to really have really great relationships and work through this anxiety that they were experiencing. And that was because the clinician that I was supervising intuitively knew that they had to work through this anxiety together. And
Hmm.
the other clinician, I think,
Yes.
she didn't know how to help this client. And that
Mhm.
happens, it happens to us all. So,
Yes. And really good example, Daniela, about right the frame we can move the amount of time that we're meeting,
mhm,
but maintain the frequency,
that's right.
right? And that's a great example of, hey, I'm willing to modify the time that we're meeting to the level that you can tolerate. And
Mhm,
as such, right, the therapist is meeting the client where they are, but maintaining the frame and not giving them that power, the omnipotence
right.
to drive and increase frequency or to modify the frequency.
That's right.
And that's that part of being real, right? You can really help the client define and distinguish, right, what's omnipotently driven, as
Mhm,
one I would refer to as that object relating phase,
that's right.
and then into usage.
Mhm,
Uh, you gave that great example earlier, right, of the child who could use informal therapy and really make use of you in that way, right? Moving into use. And
yes,
it happens at the limit.
at the
Yeah, that's
moment.
kind of the membrane between object relating and object use is the limit between the relationship.
Yes, yes, all the time. There's always in the clubhouse setting, like we do groups as well. And sometimes what will happen is a kid really likes the group. So they bring in a new member without consulting or talking with the group. And so I will say to the new member, hey, we as a group have to talk about this first. So I'm going to ask you to come next week, or I'll follow up with you next week after I talk to
Mm-hmm.
the group. And it really has created this, just setting that kind of limit too.
Mm-hmm.
It helps the group deepen, right?
Yeah.
What are we going to do here? This is our
Mm-hmm.
group. What do we want to do in this sort of situation? Um, and so, yes, setting the limit is really just
Mm-hmm.
powerful with in the community setting as well. And
Yeah.
also about the client that I talked about when adjusting the frequency is the next session came and I just kind of owned up to like, I think that was premature of me to agree. Let's talk about why you want to switch to twice a week. And we'll stick with our twice a week until we can come up with and understand why we're wanting to move it. And the client ended up staying twice a week for a while after that.
Mm-hmm.
Because it was this anxiety response of, oh man, it's getting real and I'm scared.
Yeah.
And I had heard she had told me like moments when she felt like she wanted to crawl out a window or run away when things got too close with or intimate with other people. So being able to talk about it really helped us um, do something with that anxiety.
Yes. And that increase in frequency from 1 to 2 times a week, it really accelerates this move towards dependency
Mm-hmm.
and the anxiety associated with that.
Absolutely. Shall I move us forward?
Please.
Okay. So we've spoken a little bit about enactments, or what they used to call acting out. Is there anything that you want to sort of say about the enactments, Michael, or should I just go into the case?
Just that I think from a relational perspective, we've come to understand, what's been called acting out as acting with, right? That there's two people, and
Mm-hmm.
acting out is kind of this convenient narrative that therapists and parents can put on children, that it's a one-sided affair. And
Mm.
I think, as you articulate so well, that it really is, it's dyadic, it's acting with, that there's two people who are dancing on the floor here.
Oh, yeah. Well,
Go right ahead,
yes.
please.
This example, I think, will highlight this so well. Is years ago, about 5, 6 years ago, I was referred a client from the middle school counselor, and the middle school counselor referred this client as she was going into high school, because I work at a high school center. And the way that the middle school counselor described this client gave me a lot of information. She said, she's out of control, she loves drama, and she might be bipolar. And so in that moment, I knew, anytime I sort of hear a therapist or a counselor describe a kid as out of control and loving drama, those kinds of things, my first thought is, oh, you didn't have control in the relationship. You did
Mm-hmm.
that frame, right?
Yes, yes.
And it was very true. So I started working with the student. And for the first few sessions, it was going okay. She had a lot to talk about. She'd stay for the full hour, the full 50 minutes. And then by the third or fourth session, when she'd come and sit down, she would say things like, within the 5 minutes, I only want to check in really quick because I want to go hang out with my friends. I don't have much to talk about. And so I just, encourage her to stay a little bit longer, explore what was happening there. And she'd maybe stay 15, 20 minutes. And then she'd be just like crawling out of her seat to leave. So something that I learned from you early on was, if it happens once, you observe it. If it happens twice, you're sort of scratching your head. If it happens 3 times, it's a pattern. And then we do something about it. So she would want to leave early, but on the days outside of her therapy time, she would come looking for me, or she'd see me in the hallway and she'd be like, oh my God, I have so much to tell you. Can we go meet right now? And during those times, I'd have to really disappoint her, because I either didn't have time to meet at that moment, or I only had a few minutes. And so this happened over the course of a few weeks, and I was sort of gathering information. You and I talked about this quite a bit. And what I ended up doing was, I ended up just having this conversation with her around the importance of meeting at our time, and that I really wanted to make that important. And that in these other times when she's looking for me, and I don't have time, or I'm in the middle of something, or I can't meet with her at that moment, that it's quite disappointing. And this really shot us into this place of really understanding how adults have let her down. And then she disclosed some of the abuse that she had experienced as a small child. Um, and this was in me sort of
Mm-hmm.
setting the limit, right? We're not going to meet outside in these ways. We're going to meet when we agreed upon, because it's important. And you have a lot to say, and I want to hear it all. And the way I can guarantee I can hear it all is if we stick to the time,
Mm-hmm.
the 50 minutes on this day, and we can hear all of it, and so this was a really interesting uh, case that I sort of started out on. And after that, she came for the full 4 years to therapy
Mm-hmm.
at the once a week frequency, rarely ever missed. And if she ever did miss, she would let me know.
Wow.
Yeah, it was really interesting.
Wow. It's reframing with the frame,
Mm-hmm.
helping them see the reliability and the care I've always said it's more important that the meeting happens frequently with regularity, reliability, than any of the content expressed at any given session.
Mm-hmm.
It's the way that the frame is a therapy unto itself.
Absolutely. Yes, and I think basically setting that limit of what you have to say is important and I want to hear it, and I can guarantee I hear it if we stick to this time. I think it's
Mm-hmm.
very therapeutic for her.
It really communicates value
Mm-hmm.
that you matter, you're significant.
That's right. That's right. And I wanted to see her, you know. I wanted to meet with her, and as much as she was disappointed with me for not being able to meet with her, I was also disappointed that I couldn't, you know. And so it's kind of like you said, the acting with. I was also disappointed.
Yes. Oh, it's so the interpersonal encounter, as we're highlighting here, is just so fraught with anxiety.
Yeah,
And so often the fears of abandonment are just so prominent on the front end that there's so much avoidance of starting a relationship.
absolutely. Yes. You know, and this student's already graduated, but every once in a while she comes back to the clubhouse to say hello, and she'll say things like, do you remember when I was a freshman and I was like so crazy? And we laugh about the good times, you know, and how fun that was, and how you know, how that was right where she needed to be.
Hmm.
Look at where you are. Look at where you are now, you know?
Beautiful.
Yeah.
Beautiful. Wow. If you can look back at yourself and appreciate your own development,
Yes.
what a success, right? Wow.
Absolutely. And if you're ready to go to the next slide, we
Yes.
can. It's something that you taught me very early on, and something that I teach all of my therapists, and something that I sort of explain to especially it's really hard for the new therapists to have that balance of a soft touch and a firm edge. I think a lot of them are more on the side of the soft touch. The firm edge is where they need some development around.
Mhm.
And a lot of them are starting to see the value of it as we talk through it. But maybe you can speak a little bit about it, Michael, since you helped me with this, and then I can give you the example from a client or a therapist I supervise.
Yes, well, I think about it as that relationship, built upon care, and that a caring relationship has these two components, a soft touch and a firm edge. And everybody has their tendency, right? Are they accenting the soft touch or the firm edge? Um, so they're both expressions of care that every therapist, every parent, every teacher, right, has to kind of reckon with this. And their dominant expression comes very easy, very naturally. And the additional part of expressing the more balanced relationship of adding the firm edge to the soft touch, or the soft touch to the firm edge. Soft touch is basically about kind of meeting the child where they are, tolerating their symptoms, offering support, encouragement, where the firm edge is, setting clear and firm boundaries, bringing consequence to bear to help clarify those boundaries, setting expectations that are clear to the child so they know what's expected. So the firmness and that soft touch come together in the expression of care. And Daniela, you pointed out, I think so well, that therapists tend to come into the profession as soft touch dominant, and they need to learn these firm edge approaches and the value of them, and to work through the countertransference and reframing it. Oftentimes in their mind, they think that setting a firm edge is punitive, is negative, is an expression of hostility rather than care.
Mm-hmm. Yes, they're worried about disappointing the client.
Yes.
I
And the
also,
therapists who get firm edge focused, right? Some get
mm,
very focused on the frame and rigid, and
yep.
they find themselves going rigid under anxiety.
Mm-hmm.
And they may be holding on to the frame, but they're missing the experience of the client within that place. They're just focusing on the contact boundary and the limit.
Absolutely. When I work with clinicians who start working with children that struggle with the firm edge, I always recommend that they read Virginia Axeline's Dibs in Search of Self, because she does such a good job of holding limits, but also having a soft touch in her approach
Yes.
with kids. Mm-hmm.
Great example.
Mm-hmm.
Great case material. Yeah.
But why don't I share with you the situation that came up, and I'd love to hear what you would do in the situation too, because I sort of, I helped the clinician figure out what to do next time, but it was really interesting and kind of funny. So this is a clinician who just started working with children, and it was his first session with a 8-year-old boy. And it was only 30 minutes. And in that 30 minutes, so much came up, Michael. But towards the end of the session, the little boy asked the clinician, because there's food in the office for the kids. We work in low income with low income kids, so we have food because oftentimes they're very hungry. And the little boy asked the clinician, "Can I take this cup of noodles with me?" He's like, "I can't wait to show everybody else because I want everybody else to see what I have and what they don't have." So basically, he was saying, "I want other people to be jealous of me,
Mm-hmm.
you know?"
Mm-hmm.
And my clinician knew he should have said no, right? He sort of knew that, but he didn't know
Yes.
how to do it. So he said yes.
Mm-hmm.
And
Mm-hmm.
he already understood he was triangulated in this sort of situation, and that he needed to, because I explained to him, and this was my own fault too,
Yes.
the toys have to stay inside. The materials have to stay inside. Kids can't take things outside of
Mm-hmm.
the therapy space. I said, sometimes they'll steal and sneak them. You don't have too much sort of over that. And you'll find out later because they'll bring them in or you'll see them outside with it. But
Right.
I didn't think to tell him about the food. Um, and so he intuitively
Mm.
knew that he should have said no, and he interpreted the situation to the kid, but he didn't know how to because it's the soft touch, he was afraid he might make the kid angry or disappoint him.
Mm-hmm.
And so we worked through some ideas and whatnot, but I'd love to hear what you would do in a situation like this, a little one.
Oh, I think it's a great example because you're dealing with the low income, with the deprivation,
Uh-huh.
right? With that chronic feeling of emptiness, right? Of that hole that
Yes,
hasn't been filled.
that's right.
And this idea of having something to fill the hole and communicating that to other people, right? Like you said, to bring the envy to bear, right?
That's right.
People wanted what he had. Um, and I imagine he lived, organized by envy.
Yes, what I know of the case is he struggles with like regulation. He has huge like blowouts. where he just
Mm-hmm.
is unable to manage his intensity, the intensity of his feelings, and he'll throw himself to the ground and things like that. And then
Yeah.
another aspect of this is that it's really hard for him to have friends. He's kind of the outcast. Or when he
Mm-hmm.
does play, it typically ends in conflict.
Yeah. He wants to control and have what other people have that he perceives.
That's right.
And if he can't have it, he'll destroy it.
That's right.
So they can't have it.
Yes. Mm-hmm.
Yes.
Yes.
So there'll be other times to revisit this very same theme. And that's the great thing about doing the work is that the themes just come up again and again. And
Absolutely.
and you have more clarity and you have more capacity.
Mm-hmm. That's
So
right.
it's really fine. Yeah. It's good
Mm-hmm.
to do something as long as you identify it and able to use it for learning and growth and development. And
Mm-hmm. That's totally right. Because, usually, Michael, when kids want to take things out of the office, it's to share with their friends. But this
Mhm.
was a very different case, of like, I don't want to
Right.
make everyone jealous. Um,
Yes, yes.
right.
Um,
But yes, a
right
lot of
on.
learning.
Or to share it with their family
Yes,
or to take it home and hoard it and just have like a little private item
that's
that
right.
reminds them of therapy.
Oh,
And they
yes,
don't know why. They're just compelled to take something and to organize around that object.
yes. I worked with a client, a teenager already, who at the end of our session, she would count it out. She'd take like these fruit snacks, those little pouches. She'd count out six of them and she would eat. She says, I count six out and I have one every day until our next therapy session. That was very
Wow.
interesting.
Oh, wow. That's so touching.
I
Wow.
know. But yes, the
Talking about the
frame.
oral need again, the way that if you're in this place of deprivation and you're orally organized,
Mhm.
it organizes everything. It's just remarkable.
It's remarkable. It really is remarkable.
Do you have any closing thoughts today? As
Um, well, I would say that for me, learning about the frame, working with you for almost 10 years, has really allowed me not to just like help clients, but to also like sustainably do the therapeutic work. I think having a frame also helps prevent like burnout, and it helps you feel like in control of what you're doing. And
mm,
so, as much as I think the frame is helpful for the clients, it's so incredibly helpful for the therapists too. Um, and I really enjoy working with new clinicians around this concept. It's where we spend the first year when I work with brand new clinicians
hmm
on practicum or an internship. We spend the first year just discussing and exploring the frame. And I tell them for the first 6 months, what we're going to focus on is starting and ending on time. And they go, what? And then they start doing it, realize actually how hard it is, you know?
Awesome.
Yeah.
Great. Um, to just bring awareness to the challenges of doing that, starting and ending on time.
Mm-hmm.
It's a great metaphor for the whole treatment.
That's right. And we have a part two for everybody. That's a consultation hour with a few therapists and Michael. So look out for that.
Thank you for joining us today, Psychological Explorations. Please come back for more presentations.
Thank you.
Take care for now.